So my name is Irene Lau. I'm a pediatric dentist. Today our topic is about lip tie, tongue tie, to cut or not to cut. I was actually a little bit nervous speaking on this topic because it is a little bit controversial. But let me introduce myself a little bit first. So I started my dental career more than 20 years ago. I graduated from New York University, College of Dentistry, and then I was trained as a pediatric dentist at Mount Sinai Hospital in New York. And about 15 years ago, I returned to Hong Kong, and I currently practice at two multidisciplinary dental clinics, and I started my own NGO called Hello Smile 5 years ago. And we serve underprivileged children and special needs children for their oral health care needs. Now, let's start with our presentation. So, my perspective as a dentist on lip tie and tongue tie, it's not about speech, and it's about breastfeeding and then transitioning to feeding solids and how it affects the airway and sleep and the dental and skeletal development. Now, I'm going to talk about the tongue first because the tongue is a little bit more comprehensive. So on the photo on the left, we see the very obvious tongue tie. So we can pretty much agree that this is a tongue tie. The photo on the right is a tongue tie as well, but you have to lift the tongue up to see. And oftentimes, for the past 6-7 years that I've been looking at these tongue ties, a lot of speech therapists and feeding specialists actually refer these tongue ties to me to release because a lot of times this type of tongue tie is holding the middle and the back of the tongue down and it affects the functions a lot more. And we could see, even though it's at the middle of the tongue, you can still see the tongue can extend very long. So then this gives a clue then probably sticking the tongue out may not be a good assessment to assess these tongue ties. Now, what is a tongue tie? So a lingual frenulum in 99.5% of healthy infants, they're reported as normal anatomical structure. It's observable and it's palpable. And a tongue tie or ankyloglossia is a condition where movement of tongue is being limited or restricted. And this limitation usually when the lingual frenulum is tethers the tongue to the floor of the mouth, and so it holds the tongue down. So ankyloglossia is not purely anatomical appearance-based, and diagnosis should be based on its limitation of the tongue movement and function. Now let's look at this. This is the first model here is the old model, a presumed model that we thought the tongue tie is a mucosa, and underneath the mucosa there's a submucosal band. But now we know that it's actually a mucosa. With the green is the fascia underneath, and then there's the genoglossus underneath. And the morphology is actually very variable. We can see that tongue ties could look like this. It's transparent with a mucosal fold elevating just above the fascia fold, and the genoglossus is at the base of the frenulum. Or we could see it's a little bit more opaque, and the mucosa and the fascia is drawn up, and the genoglossus is drawn up into mid-frenulum. And then we can also see these, which are thick and bulky. So the entire genoglossus is drawn up into the frenulum together with the mucosa and fascia. It's a less defined fold. And when we dissect this, underneath the mucosa, we see this whole area of fascia that arcs around the mandible. And this fascia looks very variable. It could be very thin, very thick, and this diaphragm-like structure suspends the tongue and the floor of the mouth structures within the arc of the mandible, creating a balance between mobility and stability. And because of the variation of the morphology, it is very difficult for us to just visually diagnose that it is a problem. So we rely on the function, whether the function is limited to diagnose whether we need to cut or not cut. And a lot of times, what I see clinically is kids with a lot of functional issues may have a thicker fascia, but from the outside, we're not able to see whether this fascia is thick or thin. And this fascia have two roles. So it's for tongue stability and tongue mobility. So if we stick the tongue out, the fascia attachment, the laxity of the fascia layer enables a wide range of movements of the tongue. But when we lift the tongue up, when there is tension, the low distensibility, it holds the tongue so it goes against the diverse vectors of forces. But it is because of this anatomical variation of the frenulum may create limitations to tongue movement. And this creates imbalance between the roles of stability and mobility. So what is the ideal resting tongue position? We could see on a 5-day-old infant, if we prop the mouth open, we can see the tongue lifts up automatically. It touches the palate. Now, we went over this before previously in my sleep disorder breathing talk, that correct tongue posture is when we're not speaking or eating, the tongue it naturally rests on the palate. And when the correct swallowing pattern, Goldie may go over it later also, that the tongue goes up and back. And the correct breathing, the tongue needs to go up. And this unblocks the airway so the person can breathe properly. So we could see on this diagram on the right side, when the tongue is up, our airway is open. And when the tongue is low, the posterior tongue blocks up the airway, so we can't breathe properly. And the diagram on the left here, this is for craniofacial development. Our tongue naturally is a natural expander. So when the tongue stays up on the palate, our palate grows wide. And if the tongue is down, our palate narrows up. And this has an effect on, let's say, crowding of the teeth. There's not enough room for the teeth to come in later on for our children. And so when we're sleeping, if the tongue is, if the person has tongue tied, the tongue is in a low posture, the back of the tongue blocks up the airway. So even if there's no turbinate enlargement, there's no adenoids, no tonsils, the tongue can also block the airway. And this will affect our whole craniofacial development. Now, this is a little important to understand. So when we have a tongue tie restriction, we may have issues like mouth breathing, low tongue posture, swallowing issues, neck and head tension. And when the tongue is in a low posture, the palate narrows up. And with no tongue space, we will have the same issues: mouth breathing, low tongue posture, sleep issues, head and neck tension, etc. Now, this is a study by Dr. Kim Min-oh with Chung Kung University in Taiwan. And it says short lingual frenulum may lead to abnormal orofacial growth, and it's a risk factor for SDB, sleep disorder breathing. So recognition and treatment of short frenulum early in life will improve normal orofacial growth. And so now, how does the tongue posture affect the dental and skeletal development? We could see that this is when the tongue is up on the palate. So we have the ideal bite. The jaw grows wide enough for it to accommodate all our teeth. When the tongue is kind of in the middle, it creates a deep bite or open bite. And when the tongue is in a low posture, it may create a class 3 bite, which is an underbite. And if we push the tongue out to swallow every day, then what we create is an open bite. The teeth open up and can't close. Now, this is another study by the Stanford Sleep Medicine Group. It's on ankylosing as a risk factor for maxillary hypoplasia, soft palate elongation, and they have found that restricted tongue mobility is associated with alterations of orofacial morphology. Now, to understand the growth and development of our children, how the tongue affects the jaw growth, we need to understand how they grow. So this shows that the maxillary growth, actually the jaw development, we have the greatest growth between 1 to 5-year-olds, so that's under 6 years old. And then later on, we see another peak at puberty, and that it's the mandibular growth. And so that's why it's very important that we recognize the tongue posture early on, before they turn 6, so that they can maximize their growth and development. And so craniofacial development reaches up to 80% by age 6. Now, on our children, this is my patient on sedation, MAC sedation. So we can see when we prop the jaw open, this is a normal tongue. The tongue is suctioned up on the palate. And we could see this one. This patient had a tongue tie. So when we open the jaw, the tongue is low. Now, when we could see that after a laryngophorectomy, the tongue automatically resumes its normal position. So this gets out of the airway, and we can improve the craniofacial development. Okay. Now, I do want to point out that there are other possible causes of low tongue posture, not only tongue ties. Non-nutritive sucking, which is pacifier, bottle feeding, and upper airway obstruction causes low tongue posture as well. Or low muscle tone also cause a low tongue posture. And this also could create the maldevelopment of the craniofacial growth. Now, in conclusion, so what does poor tongue function, low tongue posture, or ankyloglossia, what problems are associated with it? First, we have breastfeeding, but we have to understand that it doesn't stop at breastfeeding. Then when it moves on to when we're feeding solids, these kids may gag very easily, or they may be very slow eaters. They can't move their tongue around properly, or can't swallow properly. So then we will see a lot of this plaque on the side of the teeth. And then in turn, what happens is they get a lot more cavities. So I have a lot of children that claims that they are brushing very well or have very good diet, but if they are eating slow and the tongue is not functioning properly, then this happens. And with the low tongue posture, we know that it affects the palate development, becomes a narrow jaw. And I do also want to point out, a lot of these children, they drool a lot. I have some younger children that comes in with their parents and complains about drooling. And this is also a possible cause with the low tongue posture and ankyloglossia. Now, the tongue tie can also affect sleep and breathing. Now, when the tongue is held low, they become mouth breathers. And mouth breathers have dry teeth, and they have more cavities as well. And this also causes a narrow palate, and our kid may move on to sleep disorder breathing or sleep apnea and have behavioral issues. And at the end, they might end up with sleep apnea and may need a CPAP. Next thing it affects is craniofacial development. So low tongue posture, patients may get a class 2 bite, which is a big overbite, small chin, or underbite, class 3, and they may end up needing a lot of orthodontic treatment. And with a tongue tie, these kids may also have a tongue thrust swallow. So when they swallow, the tongue pushes out. And this results in an anterior open bite. And this also requires further orthodontic treatment. And the last thing is speech. So I've learned from my speech pathologists and speech therapists that speech may not always be affected. I guess Goldie can speak about it more later. So I rarely speak about speech with my patients, but a lot of these feeding, sleep, airway, and craniofacial development issues are actually very important to know. Now, I tossed this in. I went to a conference last year, and this is the tongue tie's effect on neurodevelopment from Dr. Scott Wustenberg. So we know that most reflexes in the babies, they start about 4 months and finishes around 24 months. And they found that tongue tie and oral dysfunction may set up the child for developmental dysfunction. And mouth and sucking connects the suck, swallow, breathe, and the moral reflex to the limbic system. And with inadequate tongue movement, it may impair the development of self-settle, self-soothing. And if the infant continues to be threatened, the need for survival reflex persists. So if our primitive reflexes do not integrate and remain retained in our system, it can cause emotional, behavioral, or learning challenges throughout life. So sleep or airway fragmentation, malnourishment, trauma can create a deviation from the optimal pathway, creating these retained primitive reflexes. And now, retained primitive reflexes is also associated with some pediatric developmental disorders, for example, ADHD and autism. And we can look, for example, if the moral reflex is not integrated properly, our children may have social and emotional immaturity or poor impulse control. Now, ankyloglossia, the functional classification, how do we assess this functionally, is now in our pediatric dentistry textbook. And this is a way for our clinicians to communicate the function of the tongue. And this tongue range of motion ratio, how we do this is we have the patient open really wide and lift the tongue up. And usually what I see is by age 3, our kids can on demand lift the tongue up properly. And so we see a grade 1 function is the it's less than 80%, more than 80%, sorry. A grade 2 is 50 to 80%, grade 3 less than 50%, and grade 4 is less than 25%. And grade 3 and grade 4, usually the function is not that great. And there's also another assessment that examines the posterior tongue. But a lot of times I do this more on adults. For children, it's a little bit hard for them to lift the posterior tongue for me to do this assessment. Now, with this classification, we can then properly communicate with different clinicians to check the function of the tongue. And there's another classification. There's actually a lot of other classifications on the anatomical feature of the tongue tie. So this is the Cotlow classification, and it was created primarily for swallowing issues. I mainly use the Coriolis classification. This is a little bit easier for me to use because, see, type 1 is at the tip of the tongue. Type 2 is about 2 to 4 millimeters behind the tongue tip. Type 3 is in the middle. Type 4 is further back. Now, with laryngophorenectomy, how I do my laryngophorenectomy in the clinic, I use the water laser, which is a dental laser. It's an all-tissue laser. It can cut both hard and soft tissue. And with kids that are over 12 months of age, I normally perform them under MAC sedation. And so this is how I do my laryngophorenectomy. I wanted to show this. This is the fascia that we were talking about that can hold the tongue down. So normally I will release this fascia also. And after I release the fascia, I'll see the muscles underneath, and this is where it stops. And I normally suture for the children. And if no suture is placed, then we will have to do a lot of manual exercise or myofunctional therapy to help with the healing, so then there's no reattachment. Now this is a little video of the procedure. You see now I'm removing the fascia that's right underneath the mucosa. Like that, okay. Now, so now, tongue tie release, there are a few factors that contribute to the failure to improve tongue function after laryngophorenectomy. And the number one is no myofunctional therapy. There's no therapy before or after treatment. So this case, this is one of my very early cases. It's probably from like 6-7 years ago. And so what I did was I released the lingual frenulum, and then I used to put not a lot of sutures, and these sutures fell out very quickly. And then what happened was, this doesn't play him at, oh no. So this was a video, actually. This is your video. This is actually Goldie. So what we saw was there's a reattachment underneath, because when the sutures fell off, the tissue wasn't healed completely yet, and there was no myofunctional therapy. The child didn't lift. So there was no myofunctional therapy, so the tissue had healed up together, and we ended up with a reattachment. And with this case, I had to redo this case later on for this patient. Now, the second factor that contributes to failure of improving tongue function is an incomplete release. So clinically, I have noticed that if I don't release this fascia, it still pulls the tongue down. And a lot of times when these cases go to our myofunctional therapists or speech therapists, they're still unable to perform their therapy properly, and so the tongue function does not improve. Now, the third issue is reattachment. So with baby releases, I normally can't put sutures in. So what happens is, if we do a baby tongue tie release and we don't do a lot of post-op exercises to stretch every day so it doesn't stick back together, we end up with this reattachment. This was my patient. The tongue tie was done somewhere else. This child was probably just a few months old. So it was done somewhere else, and we saw they ended up with this very thick reattachment. So what we did was we had to we released this tongue tie for the baby because she was not able to feed properly. Okay. Now, let's move on to lip ties. So lip ties, we have the normal lip tie, that's up here. Okay, class 2 inserts right above the teeth. Then we have class 3 lip ties beginning to insert into the anterior papilla. And these are the thickest one, the class 4 that inserts, it kind of wraps around to the back side of the front teeth. Now, what problems do lip ties cause? So babies may have breastfeeding problems because they can't latch properly, because we know the lip needs to flip up to latch properly. We may see a diastema, a gap between the upper front teeth. And we may see more cavities because the parents aren't able to lift this lip properly, and we have plaque that is trapped in here. So then these babies get more cavities on the front teeth. We can also see, because of the lip tie, we see children with an open lip posture like that all the time. This is their natural posture. And what this causes is we see children very early on with a very gummy smile. The maxilla grows forward by a lot. And we also see the front teeth may flare out when the permanent front teeth erupts with the open lip posture, with the lip tie dragging the lip up. And with speech, I know that sometimes they are not able to make the sounds that they have to put the lips together. I guess Gori will explain more later, yeah. So let's go back to our growth chart. Maxillary growth, remember, our greatest growth is under 6. And so the greatest growth between 1 to 5 year old. If we're able to spot the lip tie early, the open lip posture early, then we won't end up with a lot of children with these very gummy smile very early on, because this bone, once it's grown out, we can't put it back, and they may have a very gummy smile as an adult. Now, this is a cephalometric tracing where our orthodontists use to do measurements. And we can see that this point, I put the circle in the wrong spot, it should be right here. Okay, so the NSPR line is the most mature during the first 3 years, and it's closely approaching adult size by 4 to 5 years old. So this is why it's very important that we catch these open lip posture that's dragged up by the lip tie early, so they don't end up like that. Now, how I do my labial frenectomy, it's the same way I use the water lace, but I don't suture for the lip. And normally I rely on the parents to do some lip exercises to prevent reattachment. Now, the post-op stretches are OMT for labial lingual-frenum. So we start the lip stretches first day until it fully heals. That's about 2 weeks later. And they do this every day. I have them do about 5 cycles a day. And with the tongue, if there's no suture placed, they need to start stretching the first day for at least 2 to 3 weeks. And with suture, I don't have them start lifting or doing any exercise until day 4. And then the next week, they will start OMT or speech therapists with the myofunctional therapist or speech therapist. And this helps with the healing and prevents reattachment. Now, I don't think I have time for this, but this is a good video to watch. Dr. Richard Baxter from the States, infant stretches, just to demo how we do these stretches. Now, that's for the tongue. So it's very important that after baby frenectomies, the parents learn how to do these stretches at home to prevent reattachment. Okay. Now, move. And then, this is just, we can skip this one. And this is myofunctional therapy. Now, I just have maybe like a couple cases to go over. So this is my patient. She had an underbite. And this underbite, she has a tongue tie. So we call this a functional anterior crossbite. She did not have any family history of underbites in the family. And this is how her function was. She is not able to dissociate the tongue with the mandible. So when she moves her tongue, the mandible juts forward. And as a result, she has this bite. And what I did was I released her tongue tie, so her tongue can move up properly. And this case happened during COVID. So what I asked them to do is do a lot of these tongue exercises, tongue up exercises. And eventually, I did not need to put any appliance in, and her bite had self-corrected into a normal bite. And I've done several cases that are similar, and clinically, I see that I could only achieve this when I release their tongue under 3 years old. And if I release it a bit later, it changes. I will have to put in an appliance to correct their bite. Now, this is another case. A patient came in. The chief complaint was he's very slow eater, mouth breathing, snoring at nighttime. So I had referred this patient to a speech therapist for oral myofunctional assessment and to the ENT as well. So they have found that patient has oral dysphagia and recommended a functional release. ENT diagnosed the patient with just allergic rhinitis. So what we did for this patient is I released the tongue tie and did a lot of OMT. And then what we did was, we see that this jaw development, because of the low tongue posture and the tongue tie, the palate's quite narrow and there's no space. And so what we did was, I gave him an expander. So we expanded the upper arch to correct the bite. And after expanding the upper arch, the patient actually stopped snoring. And he actually told mom that he likes turning this appliance because it makes him feel good. Now, this is another, my last case. This is a little bit more comprehensive. This patient started off with, she has an anterior open bite, and she was a thumb sucker. And what happens is she also has a tongue tie. And it took me 3 years to correct her bite. What happened is the thumb sucking holds the tongue down, causes a low tongue posture and a tongue thrust swallow. So it's like this. She pushes out when she swallows, and we swallow at least 1,000 times a day. So this pushing out created an anterior open bite. She also has a tongue tie. So the tongue tie held the tongue low. There's no way she could lift the tongue up. So also contributed to her anterior open bite, her tongue thrust. So what we did first for her was, actually, let me see, where's that slide? So what we did for her was first, I released the tongue tie first. And this is actually a patient, Goldie's patient as well. So she did a lot of myofunctional therapy with this patient, pre and post therapy. And initially, we did some conservative appliance therapy. This is called a habit appliance bluegrass. So this blocks the tongue from coming out, blocks the tongue thrust from coming out. And then this little ball is supposed to attract the tongue to go up so it could practice staying up. But according to Goldie, this did not work. This appliance actually, it's no use. So what we did later on is I used an aligner, the clear aligner, to close her bite. But Goldie actually did a lot. Do you want me to play the videos of her? Yeah. Goldie did a lot of therapy for this child. And I do want to show the other videos. Yeah. Okay, pre-frenectomy. Pre-frenectomy video. This is before we did the tongue tie release.
4, 5, 6, 7, 8, 9, 10. Good job. Okay, open that. Bite on the chopstick. Good. Click. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Good job. Okay, open and bite on the chopstick. Good. Click. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Good job. Now go. Lolly.
Lolly.
No.
Lolly.
Good.
Lolly.
Good.
Lolly.
Good.
Lolly.
Good.
Lolly.
Good.
Lolly.
Good.
Lolly.
Good. Keep doing.
Yeah. Lolly.
Good. 3 more times.
Lolly.
Good.
Lolly.
Good.
Lolly.
No, this one's not okay.
Lolly.
Lift it up higher.
Lolly.
Good.
Lolly.
One more time.
Lolly.
Good. Better. Now go. Lolly.
Lolly.
No.
Lolly.
Good.
Lolly.
Good.
Lolly.
Good.
Lolly.
Good.
Lolly.
Good.
Lolly.
Good.
Lolly.
Good. Keep doing.
Yeah. Lolly.
Good. 3 more times.
Lolly.
Good.
Lolly.
Good.
Lolly.
No, this one's not okay.
Lolly.
Lift it up higher.
Lolly.
Good. Alright, sit back. Okay, don't move, okay? Một dọc. Okay. Alright, open your mouth. Good. Wider. Tongue up all the way up. Good job. Hold it there. 1, 2, 3, 4. Good. Alright, good. Move bigger. Good. Alright. Okay. Turn your tongue down. Good job. Yes, good. Well done. Good. Okay, good. Alright, tongue out. Don't move your jaw. You're moving again. Open. Good. Tongue out. Like that. Straight. Here. Good. Yeah, like that. Longer. Well done. Hold it. 1, 2, 3.
Okay. So this is my last slide. So conclusion to cut or not to cut. First, we need to identify the structure. And then we also have to identify where there's any limitation in function. And for infants, normally I work with IBCLCs or certified lactation consultants to assess the function. And for toddlers and young children, I normally have my speech pathologist or myofunctional therapist assess the function before we decide whether we need to cut or not. Sometimes myofunctional therapy is sufficient to improve the function. And we need to remember that lip tie and tongue tie not only affects speech, like we used to think, it affects breastfeeding. And then when they transition to solids, it affects the airway and sleep, affects the dental and skeletal development. So early intervention and multidisciplinary approach is the key to treat these patients.